Welcome to Chapter 2, Workforce Safety and Wellness. This chapter is about protecting you, your body, your mind, your career, and your ability to keep showing up for your patients safely. On the NREMT and in real world, safety isn't a suggestion, it's the foundation. If you're unsafe, you become part of the problem and potentially another patient. Let's start with sharp safety. Proper disposal helps prevent exposure to blood-borne pathogens like HIV and hepatitis. The big rules are simple and non-negotiable. Do not recap needles, do not bend or break needles, dispose of used sharps immediately, and in an approved closed container. Most needle sticks happen when people are rushed, distracted, or trying to be careful while doing something they shouldn't be doing, like recapping a needle. This image here reinforces what we just said. Sharps go into a closed, rigid, clearly marked container immediately, not "I'll do it in a second." The second you delay is when accidents happen. Scene safety. Scene safety begins as soon as you're dispatched, not when you arrive, when you're dispatched. You should already be thinking, what is the call type? Are there any hazards, violence, HazMat, traffic, any other considerations? And once you arrive, you continue protecting yourself the entire time. Scene safety is not just a checklist item, it's continuous and ongoing. The image here is a great reminder that secondary crashes are also a very real thing. If your scene isn't well marked, another vehicle can hit your ambulance or your providers. You can do everything right medically and still get hurt if you ignore traffic safety. HazMat, or hazardous materials. Identify what you can from a distance. Don't enter the scene unless it's safe, and if you ever suspect HazMat, our job is to stage and isolate the area and wait for appropriate resources. We're not expected to become HazMat technicians on the spot. The image shown here is the ERG. You're not expected to memorize it, but you should recognize it, know where it's stored on your apparatus, and be familiar with it and understand what it's for, which is identifying hazardous materials and guiding scene control and emergency care considerations. Electricity. This is beyond the EMT scope, meaning you're not here to solve any electrical problems. Mark off a danger zone and wait for utilities or fire to manage it. With lightning, you should remember that a repeat lightning strikes can occur and ground current can injure people even without a direct hit. Fire scenes include hazards like smoke, oxygen deficiency, high heat, toxic gases, and potentially structural collapse. If you don't have the correct protection and training, you don't belong in the hot zone. You should operate only where the fire department says it's safe and with proper protection. This figure here is a reminder that EMTs who are also firefighters may be trained on SCBA and have turnout gear and operate differently. But for EMT only roles, we're not going to be operating in any of these environments. Vehicle crashes. These are common and they're often full of hazards, to include traffic, unstable vehicles, down power lines, sharp metal, and glass. And this is why we wear protective equipment and why we control the scene before we rush in. Let's talk scenes of violence. Violent scenes can include assaults, hostage situations, riots, or mass gatherings. The key point here is that we do not secure violent scenes. We stage and wait until law enforcement makes it safe for us to enter. Mass violence. It's important that we know who is in command. We stay vigilant for ongoing threats. We allow law enforcement to clear the scene. And if projectiles are involved, we need to make sure that we have protection. Cover versus concealment. Covering is going to stop bullets, such as like a concrete wall or something hiding behind a fire engine, something like that. Whereas concealment is going to hide you, but not necessarily stop bullets. For example, drywall, furniture, things of that. Understanding this difference matters in any kind of active threat situation. There are prevention recommendations for preventing violence, such as training and practicing identifying the violent scenes, de-escalation strategies, and establishing strong interpersonal communication and dispatch alerts for known threats. Prevention is not a skill set, but we do get better at reading scenes through experience. Protection recommendations include self-defense and learning escape techniques, physical and chemical escape techniques, proper fitting and use of body armor, and training for operations with law enforcement. The theme here is preparation and coordination, not improvising. Personal protective clothing is critical to our personal safety. We need to be familiar with what our job requires and what conditions we're going to be operating in. If we're operating in cold weather, think 3 layers. If we're operating in a fire situation, turnout gear is designed to protect us against heat, fire, sparks, flashover, etc. The picture here shows turnout gear, which is designed for firefighting operations. Again, the PPE matches the hazard. Now we get into some more common protective items. Gloves are going to protect us from heat, cold, cuts, and however, can reduce our manual dexterity. The gloves shown here are more firefighting structural gloves versus the type of gloves that we would wear on EMS calls. Helmets. They're going to protect us from falling objects. You may or may not be issued one of these depending on your role, but keep in mind that this is going to protect you from any kind of hazards that could strike your head. Steel-toed boots are preferred. They're going to protect our ankles and keep us out of debris and weather, and they also keep our feet dry in the snow and rain. Some more examples of protective and clothing include eye protection. These are going to be glasses with side shields, ear protection, usually in the form of foam earplugs, skin protection, and body armor. Our PPE selection is going to depend on our anticipated exposure. EMS is a high-stress job. The goal isn't to never feel stress. It's knowing what causes it and how to manage it. This slide introduces the general adaptation syndrome, which involves the alarm response, a reaction or resistance, recovery, or exhaustion. If you never recover, you slide into exhaustion, and that's where mistakes, illness, and burnout live. Physiological signs of stress include increased respirations and heart rate, increased blood pressure, cool and clammy skin, dilated pupils, tense muscles, increased blood glucose, perspiration, and decreased blood flow. This matters because stress is going to affect our performance. Our body is preparing to survive, not necessarily think clearly. Stressors include dangerous situations, physical and psychological demands, critically ill or injured patients, dead and dying patients, and overpowering sights, smells, and sounds. EMS is unique because it engages all of your senses and all of your emotions at once. Add to that multiple patient incidents, angry or upset patients, families, bystanders, and the unpredictability of EMS. It's not just the cause, it's the constant unknown. There are different types of stress reactions. You can have an acute stress reaction, which is during the event, a delayed stress reaction, which is after the event, or a cumulative, prolonged, excessive stress over time. Knowing the category helps you recognize what is happening and what support is appropriate. Physical symptoms of stress include fatigue, appetite changes, GI problems, headaches, insomnia or hyperinsomnia, irritability, trouble concentrating, hyperactivity or underactivity. If you're seeing any of these symptoms, you need to take it seriously and not push through it. Psychological symptoms. These include fear, dull or non-responsive behavior, depression, guilt, oversensitivity, anger, irritability, frustration, and more. These can show up in how you treat your coworkers and your patients. This is why self-awareness really matters. Critical incident stress comes from acute, severe stressors. Mass casualty incidents, severe injury or death of a child, crashes caused by emergency providers while responding, death or serious injuries of a coworker in the line of duty, and more. These are events that can reshape people. Post-traumatic stress disorder, or PTSD. This may develop after psychologically distressing events. It often involves re-experiencing the event and over-responding to the triggers that recall it. The key is, PTSD is a real medical condition, not a character flaw. Critical incident stress management can help providers relieve stress. It can occur formally or even on an ongoing scene and is facilitated by trained professionals. Support early and often prevents long-term damages. Burnout. This is a combination of exhaustion, cynicism, and reduced performance from long-term job stress. It can affect the EMT, the crew, and the patients. This is where compassion drops, shortcuts happen, and safety issues increase. Compassion fatigue, or secondary stress disorder. This is a gradual lessening of compassion. Signs include high absenteeism, inability to work in teams, lack of empathy, and a judgmental attitude towards your patients. If you're starting to hate people, that's a sign that you need some support and recovery. Responder risk for suicide. Emergency responders have a higher risk of suicide than the general population, and this job and the stress associated with it is a major contributing factor. The takeaway is not fear, it's awareness. There are organizations and mental health services specifically for first responders. Reaching out is strength. Many factors influence how patients react during an EMS incident. Our job is to quickly and calmly assess the patient, family, and bystanders. We need to use a professional tone and show courtesy. Let the patient express their fear. Remember, this may be the worst day of their life or the worst thing that's ever happened to them. Respect their cultural and religious beliefs and communicate. And these small communication choices can prevent escalation. In EMS, you'll work with coworkers of a variety of different backgrounds, beliefs, and values. Culture includes nationality, age, disability, sex, sexual orientation, marital status, work experience, and education. We need to communicate in a way that's sensitive to their needs, stays curious, and open-minded. Good teams don't require sameness, they require respect. Sexual harassment. There's two types: quid pro quo, which is a request for sexual favors tied to job benefits, and hostile work environment, jokes, touching, comments, etc. Report harassment to your supervisor immediately and keep notes. This is about safety and professionalism in the workplace. Substance abuse increases risk and leads to poor decision making. This slide encourages seeking help or confronting an addicted coworker appropriately. Many agencies have an EAP or an employee assistance program that will provide confidential help. The expectation is safety and intervention, not ignoring problems. Finally, a strong injury or illness prevention program. Some things that this would include would be management and leadership, worker participation, hazard identification and assessment, hazard prevention and control, education and training, and program evaluation and improvement. This is a system-level side of safety and building an environment where injuries and illness are prevented and not just reacted to. In conclusion, Chapter 2 is your reminder that EMS is a career, not a sprint. Your safety practices, protective gear, and stress management determine whether you can do this job for years without burning out or getting hurt. If the National Registry is going to ask you what to do, remember, safety first, follow policy, use your resources early, and don't ignore your warning signs.